Hey everyone, welcome back to all my listeners. Today is Wednesday, June 19th, 2024. My name is Sonal Patel, and this is the Paint the Medical Picture podcast series. All right, you guys, I'm on a roll now, and I'm including these bonus episodes of my Compliance Capers series that I've been telling you all about from week to week. Those are my collaborations with my very good friend and colleague, Betty Hovey, and they're featured on LinkedIn Live and my YouTube channel as well. But I wanted my podcast listeners worldwide to catch up on Compliance Capers. This is episode 3 in Compliance Capers. Enjoy. Good morning, my friend. Hey, Betty.
Hi,
Hi, everybody.
hey,
So good to
good.
see you today. Welcome. Welcome to yet another episode of Compliance Capers. I'm so excited, right? This entire month of January, we are going to be focusing on this new collaboration that you and I have developed together on Compliance Capers. So, we really wanted to bring this idea to light, especially on Fridays, right? To end cap our week. We are busy professionals during the entire week, Monday through Friday, sometimes even on weekends, but we really wanted our audience to, end the week off remembering compliance, and seeing these cases that we wanted to highlight at the end of the week. These cases that involve a lot of capers throughout the nation based on press releases that are issued by the OIG, by the DOJ. So, in previous episodes, we've already talked about some hot button issues, but today I pulled some cases in late December of 2023, so just a few weeks ago, on something called medically unnecessary services. So that's kind of a big item, right, Betty? I mean, these are things that you and I have seen definitely over the years. But in terms of this pandemic that we were all hit with, right, for the past 3 years, these types of medically unnecessary services kind of went haywire, did they not? And I think you can help the audience understand a couple of these cases that we've pulled in terms of, it's not really fair to many of our vulnerable population in Medicare patients, right? It's not safe for them, obviously, to undergo these types of services that are not medically necessary. So I know I would love to hear some more.
Yeah, well, we took a look at for today. There's a couple cases that were involving medically unnecessary services. One is a nurse practitioner in my great state of Florida. So, we seem to, I think because we have a high Medicare population, everybody always, even
That's
when
true.
I wasn't living in the state, everybody was just like, oh, it had to happen in Florida. So that was always the thing. But this nurse practitioner happens to be in Florida, but she was involved in a DME scam, which we see a lot of. When I go out and I look at the DOJ press releases and stuff, when I go looking through them, it seems like, it's just DME. There's a lot of it. And with DME, they have to be seen by a physician. They have to have a prescription from a physician or an APP, someone who is medically appropriate and can do so. And then they have to take that prescription to a Medicare approved DME supplier. So what this nurse practitioner was doing, and we don't have to say accused of doing because she was actually sentenced. So what she was doing was she was working with a DME company and just signing these orders for DME without ever seeing the patients. So the company would talk patients into getting things and that they didn't need. She would write the orders for them and they would go to them. And, so some of it was DME, but then also there was genetic testing involved where she was writing orders for things. She also was involved with telemedicine.
Oh, wow.
And just like we had discussed on the previous episode, this lady somehow was billing over 24 hours a day of telemedicine visits with patients.
Yikes.
So
Wow.
once again, it's one of those things where it's just like, I don't know how people think that that's not going to get caught. It's just like, all you have to do is plan it up, but either she didn't perform them, or it was like an unnecessary, hey, how you doing? And then they would be off, and then she's billing for, longer amounts of time, higher levels of service, things like that. But this nurse practitioner actually was sentenced to 20 years in prison. So
wow.
she really is paying, but her fraud scheme was for over $192 million is what they said she got out of this scheme. So I think 20 years is, kind of evens that field out for them with the 192 million.
Absolutely. Wow.
The other case is a cardiologist. Now this one is just being put out there. So this is allegedly this cardiologist.
Okay. And alleged. Okay.
Yes. He allegedly was getting patients that would be referred to him and doing unnecessary procedures, medically unnecessary procedures. And that's the one that really, really irks me, is when they do that. He also did medically unnecessary testings, including PET scans. And, with the PET scans, that's when they put that little nuclear tracer. It's a trace amount of radioactive tracers into the body that go into the gamma rays. And when I look at this, I always think of the Incredible Hulk.
The Incredible Hulk, yes. The gamma rays, yes. We grew up with that, yes. I love the Hulk.
But that it makes it to where they get the images that they're looking for. So he's doing like PET scans. They also said, let me see, stress tests, echoes, carotid Dopplers. So just a bunch of
excessive testing
studies that patients didn't need, just to prove that they had something. And then if they didn't show anything, they were actually fudging the patient's medical records. So they were placing things in there that the patient didn't have to substantiate the fact that they wanted to do these peripheral vascular procedures on them then. So when you look at the medically unnecessary issue, a lot of us from a non-fraudulent standpoint look at medical necessity and then look at, tying that to your ICD-10 kind of thing to make sure you're showing medical necessity so you get paid properly for what you're doing. But in these cases, the patients just didn't need them in the first place, and, they were being milled through. So a lot of damage, especially from that cardiac surgeon, was, a lot of harm being done to these poor patients. So, they're looking at him now. It's out of Brooklyn. So out of New York is where this physician is located.
Wow, Betty. So what you've identified in these two cases are definitely this kind of stuff happens across the country, right? Florida, so Deep South, and New York, right? The Northeast. So this kind of stuff can happen anywhere. But in terms of, spotlighting these types of cases for medically unnecessary, the patients are at harm. In both of these cases, right? Especially the second case, right? The cardiologist, because when you're doing those excessive tests, okay, yes, the monetary value might be a little bit lower, but it's test after test after test on these patients that don't require it, right? And those PET scans, like you and I know, are radioactive, right? So that material to the patients again and again and again cause risk and harm and, other indications to a vulnerable population who already have existing health issues, right? So lots to think about there. Lots of reasons, like why were they doing that? Again, for the monetary needs. And it's simply abuse. They abused the entire system, right? Um, wasting and performing those tests again and again and again. And I believe in that case, this cardiologist, was he a surgeon? Because I believe the press release also goes into detail that we were discussing offline, which we can bring online now, that he performed peripheral vascular procedures on the lower extremities for these patients. So those are invasive procedures. So we've moved beyond diagnostic testing, right? We've moved beyond it and into actual procedures that these poor patients did not need. And so things like that are just amplified in these types of cases. Where the government can identify, like we talked about in previous sessions here on Compliance Capers, where the government has access to your claims data. So they can analyze those vast volumes of these types of procedures that are going on to the patients at your practice. And so, again, it is not a good look when they can corral in all of these claims and then go back and ask for documentation and actually poke around, right? They also have the right to interview patients. They can go ahead and interview and talk with your staff, with people in your front office to see what's going on, right? They will really poke around and investigate to get to the bottom of what is happening at the practice. So these types of capers were huge, right, during the pandemic. And that first one with that nurse that you talked about in Florida, we saw, I don't know, over 20 or more cases, right, that involved that type of blatant abuse for the telemedicine space, right, where these nurses, doctors, whoever are signing off on these DME orders, again, without the perfunctory, requirements. You have to see that patient beforehand. You have to see that patient face to face and give them an order. These can't just be like blanket orders. I've never seen you, but I'm going to go ahead and start prescribing you all of these braces and supplies that you don't need, right? And those orthotic braces are big ticket items. And then if you do it again and again and again consistently, that reimbursement adds up.
That's and going to your point of the how they're looking at things and who they can talk to, on the EOBs and the EOMBs, the benefits explanations that the patients get, they have, you have questions about this, or if something doesn't look right, here, call this number.
That's right.
So the patients, when they call that number, that's the fraud number, that, goes to the people that are looking for those kinds of things. So, patients, and a lot of patients are getting pretty savvy when they're looking at stuff. I know my clients are saying that they get a lot more calls from patients, hey, what's this? And why was I billed for that? And I don't remember this. And, with the older population, sometimes, they may be calling and it might be unwarranted. They just don't remember, they were in the hospital and they were out of it when the physician went in and saw them, because of whatever their condition was. So then they get this bill. I never saw it. Well, yes, they saw you every day for a week, so we're not talking about that. So they'll have questions, and they're getting to where they're asking more about things and questioning why things are. You see the commercials on TV, if something doesn't look right on your bill, make sure you contact somebody. Those programs, especially the Medicare program, they're running out of money.
They are.
So
they are.
And that's where I look at it. And I know, you do too. It's, we need to keep the program, it's a benefit that all Americans were paying into, so we should have it when we retire, but, and it should be paying physicians and APPs and hospitals and for the services they're doing. but we need to make sure the money's going just to them and not to these people that are, doing all of this, billing for stuff they never did and making stuff up and everything else just to bilk the program. That hurts all the other ones that are doing it right, and why, we have problems with payments and fee schedules and things like that when you're thinking of all this money that these fraudsters and people pulling these capers are taking out of the program. We need that money or we won't have it when we need it. So
Exactly. And we are coming of age, right? In a few years, we will be we will be, right? And there won't be anything left for us because of all of these types of capers, these abusers, right? That mishandle the trust fund of Medicare, right? That is why, and I know, our series on these capers will definitely uncover more in terms of, the different arms that the CMS has, right? For what they can do to provide not only education, but how they can recover funds, right? How they can go back and start recouping. And so that's a lot of the work I know that you and I over these years have helped, work on, try and really get in there and look at documentation, right? That's our overarching, goal, because we are proactive advocates and, advocates for our APPs, our physicians, all of our healthcare workers. We are very proactively trying to assist them in cleaning up their documentation to make sure that it actually does support all of these EKGs that are done, so many times in the month for these patients. If it's being done appropriately, and the applicable LCD or NCD is actually being followed and is evident in the documentation, we can go ahead and support that, But if we're seeing these things in volume, because we're certified coders, we know that there are certain MUE limits on certain items, certain services. And so we know that that's just not possible, right? And so we have to try and stop that behavior as well. Because, just because the payer doesn't have the appropriate edits in place, I know you and I have seen that time and time again over these many years. Even if their edits are not working or they're malfunctioning in a certain year, that doesn't mean that we can't be advising our providers that they have to stop what they're doing and slow things down and meet the MUE criteria. And that's it. You can only do 2 of those, and that's it. We don't want to see you doing any more because there's an MUE.
Yes, exactly. Or the OIG will take a look at something and it'll be a project on the work plan. And so maybe it's something that CMS up until this point just hadn't been looking at. So the OIG will have a project on it and they'll say, we found when we asked for records and we looked at these things that these things seems to be being abused, and we recommend to CMS to start auditing for this and to start doing takebacks. And CMS says, "Hey, we're happy to take, we're happy to take back that money.
We're happy. We have RAC auditors that's what they're there for. We're happy to utilize them."
That thing in the office, when you hear, for those of y'all that are listening and watching, when you hear the physician or the office manager giving you we get paid for it. Just because you got paid for it doesn't mean you're going to get to keep it. Right. So maybe they didn't have this edit in place before, and now they're seeing that, or they put out an NCD or an LCD that says we're only going to pay for 1 of these every 6 months or 3 of these per year or whatever, where they put a frequency limit on it. And then all of a sudden you're bucking up against that frequency limit. You could bill it till the cows come home. You're not going to get paid for it after you hit whatever that limit is. Unless there's a darn good reason and you go through the steps to, discuss that with CMS about trying to get that overruled for that patient. But most of the time there's a frequency limit. It's a limit and that's it. So just because you got paid for it doesn't mean it's right. And what I've told one of my clients had said that to me, well, it must be right because they paid me for it. And I said, well, then when you get a denial, it must always be wrong. You must have always been wrong. So if they only pay you when you're right, if they deny you, that means you must have been wrong. And so all of that gets written off, right? You never get to appeal anything because it has to have been wrong because they didn't pay you. Well, of course not. I said, well, then every time they pay you, it doesn't mean that it's right. So you have to make sure all this stuff does is go from now, your computer or clearinghouse to their computer. Nobody is reading or looking at any claim forms anymore. When I first started, good Lord, we were typing them, the 1500s, and they were the HICFA 1500s back then.
Yes. Yes, that ages us, but we still call them HICFAs. We don't call them CMS 1500s.
Now I just shorten it to say 1500 because I don't want to catch myself. So I just said the 1500. And I used to have to hand sign all the claim forms. That was one of my jobs. On Fridays, we would print out all the claims on Thursday. All day Thursday claims would run on those printers. And then on Friday, one of my jobs was to sign because you couldn't use a stamp. It had to be a hand signature. So all morning I would just sign one after the other oh, good Lord. I hated it. I could not wait for Friday to be over. It was just like, seriously, somebody's going to do some of these, so then, yes, they were being looked at because that's the only way we had the system done. But now nobody looks at anything. You don't look at the 1500 before it goes out your door. Well, the payor's not looking at it either. The computer system's adjudicating it. So just because it got paid doesn't mean anything. If it's got a CPT code and it's got an ICD-10 code and there's not some kind of edit about, that you can't do that for that, you're going to get paid. So it's not about getting paid. It's about keeping the correct payment. That's what's important.
Yes, that is well said. Yes, it's about keeping the appropriate reimbursement that you receive. Because like you said, in the majority of these claims that go out today, right, for quite some time, it is all electronic. Yes, you might have a good scrubber, so things might get held up for a moment if there's a mismatch in the patient information on the claim, just something really simple. The scrubber might actually catch something, but in terms of the edits that are at play or not at play on the payer side, the majority of claims, like we keep saying, are going to be promptly paid within 2 to 3 weeks for each and every payer. And that doesn't mean that reimbursement is appropriate or correct, right? Because it's simply based on the red CMS 1500 form. It's only based on that, right? It's not based on anyone's eyes looking at documentation that is coordinating with that CMS 1500 claim form, right? That's the most important thing. A big takeaway is that you have to remember that what you're doing in terms of your service lines at your practices are twofold, right? It's not only what you're billing out on claims, that documentation in the medical record that you're typing up in the EMR at the end of your day has to support those claims that are being pushed out from your practice. Both of those things go hand in hand. And it's just a matter of when a payer is going to come back and take a look at you and ask for those records, ask for that evaluation and management service record to be looked at, ask for those procedures, ask for those injections, ask for, the laundry list of things that go in supporting the claims that you're billing out. So more often than not, it's a lot of other, subsidiary information that is going to support the actual claim, like your DME orders, your patient consents. All of those types of things have to be found within your EMR system somewhere, because that's what the OIG, CMS, that's what everybody's asking for. They want everything, not just that SOAP note from that date of service. It's not as simple as just those, 5 pages. Sometimes it's a lot more, because it's all of that other information that is going to actually back up your entire claim.
Yeah, and as far as DME goes, like with that first case, I've done a DME audit for one of the MACs, and when you take a look at the stuff from a DME perspective, I mean, they really want extensive records. They look at the order, they look at the diagnosis from the order, they look at what the DME company has done, they look at for orthotics and stuff, they have to come in and be fitted, so there's specific requirements they have to meet for that, and there's specific things, checklists of different things that they're looking for to support those medically necessary services. That's that's always something when you're looking for those of the rest of everybody that is not trying to pull a caper, is trying to do things right. You have to be looking at those things. Look at the LCDs, look at the NCDs. If it's a commercial payor, look at their medical policies. Sometimes they're a little hard to find. They're making them easier, but on some of them you have to log into your portal and have your NPI or your tax ID and all this other kind of stuff. But they're there. And take a look at the policies that they have on certain things. I just posted one on LinkedIn for Cigna, who is taking a look and putting some MUEs on COVID-19 stuff. So they're out there. You just need to go look at them, make sure you're looking at everything. Medicare with their feet stuff. They'll you have to have this many class A or a class B finding, and the patient has to have all these other different criteria met, and they're telling you what they're looking for. So if you read those things, then you know what you should find in your documentation. So when you get a request for records, you're like, oh, okay, well, here you go. I know everything's in there because we followed the LCD, we followed the payor policy, and we have all those criteria in our documentation in the note, because that's what it's going to come down to. As we said again on a previous episode, they don't want to hear your story, and they don't want to hear you telling them that you really remember seeing this patient. They want to go by what you've got documented. So take a look at all of those things that apply to whatever things you're doing in your practice, and make sure those are the things that are covered in your documentation. Then you don't have to worry about it, because these guys, they should have all that stuff taken away from them. That woman should have gotten the 20 years. But when you see practices that are doing things, actually doing them, and then a payor comes and says, well, you didn't document this and this and this, so guess what? You're paying it back. Oh, I hate those. I hate when that happens.
It's not fair. Exactly. Because we know so many good practices, right? Yep. These are really bad capers, right? With a lot of unscrupulous folks.
Yes.
The people that you and I deal with are very good physicians and APPs. And again, like we talked about in a previous episode, when the mistakes are small, they are preventable. Like you can make quick corrections, right? You can take action quickly because you've looked under the hood, you've identified the issue promptly, you can make a corrected claim even, right? Within time, because you've identified the issue within 1 month, nice and quick. Right. So there's no problem there. But yeah, really, really good points that you've made. We know that CMS does not accept conversations with our providers as, we can pay you now because we talk to you and we see all of your, deep thoughts.
You look like a good guy. Yeah.
You look like a good guy. Like, no. They don't do that. They don't operate that way. They only go on, objectivity. And that is in the black and white evidence found in the EMR. So again, Our
Great point.
conversation together today is all about doing the right thing, capturing everything at the service encounter in the EMR, in the documentation, again, to support the medically necessary services that we know you are providing at your practice. So
Yeah,
just make sure everything is well documented. And even if it's tucked away in the EMR, in your Epic systems or wherever things are housed, you can feel confident, right, that that order is actually there. It's hidden away in that tab within Epic, but
yeah,
CMS will know it because you've pulled it out properly when it comes time for a documentation request letter, that
yeah.
ADR letter that comes to you. You and your team know, oh, okay, we've listened to Compliance Capers with our good friends here on LinkedIn Live today, and they've advised that we should know to pull all of the subsidiary information as well, right, to support our claim, the orders, the injections, the consents, the drug dosages,
Yeah.
everything to help
Excellent,
support it.
excellent point. That's yeah, that's so true that I see too, where they have sent information, they get the ADR, they send off and they just send the note. And then they
Yeah.
get denied for the
And
stuff
they
and they
don't know
come to
why.
me and it's like, why? And I said,
Yeah.
well, did you send the order? Did you send the film? Did you send it? Well, no, we just something. I said, well, okay, you got to send everything. So that is such an important point, Sonal, is to really make sure if when you get those record requests that you send everything they need the first time. If they don't
Yeah.
get it, they're going to deny it. And then you're
Right.
going to say, oh, well, wait. And then you're going to have to ask them to look at it
Right.
again. And then once again, it's just delaying and making
Mhm.
that process longer and longer, making the office more and more anxious,
Yes.
and everybody's just like, oh, they denied every one of them. Well, okay, you didn't get them what they needed in the first place. So,
Right.
now you have to do it again. And, staff time and people pulling and now repulling, looking at those records once again in the EMR. It just makes it even drag on longer than what you want. You want to get it done, get them what they need. Let's be done with it. Again, there might be one or two mistakes in there. Everybody does them,
Right.
but there's not going to be an overarching thing of this is just totally out of the ballpark. And you just recoup whatever the mistake was or two that you made, but you're done with it then. Not this
Right.
dragging on for months and months and months of back and forth because you're not getting them the right stuff. So yeah, that's a great point.
That's right, Betty. Well, my friend, thank you so much for coming on today on our compliance capers on the medically unnecessary services. I really hope our audience today has a lot of key takeaway points that we've helped make today. Hopefully our sessions together are going to give you some really great advice and some great tips on, how to stay out of trouble, how to avoid being on these hit lists
Yes.
of capers, right, that the OIG and the DOJ publish very, very often.
Yeah.
I know all of our providers are good ones, and we're not going to see them on these capers lists. But hopefully, everybody who is watching this will take it to heart as well, and stay clean, stay proactive in your approach to compliance from month to month to protect your practices.
Yep.
So, thank you so much, Betty.
Thanks. Fun to talk with you always, Sonal.
All right. Well, I'll see you next time, my friend.
Of course. Thanks, y'all.